Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode of the show, we speak to Leslie Faria Mendes about Obsessive Compulsive Disorder from a clinical psychologist perspective. Leslie Faria Mendes, welcome to the show. We're really glad to have you on board. Thanks very much for doing this.
Thank you guys for having me. It's a real privilege to be a guest on your show.
The pleasure is always ours. And, I'm going to ask Shaz just now, how she got in contact with you, because that's always an interesting story. But before we do that, I just want to introduce the topic. We're talking about OCD, which is amazing. We had someone on recently. It was actually a psychologist at one of the psychiatric day clinics, Avexia. And we spoke about personality disorders. And I completely forgot about OCD, and he actually mentioned OCD as one of those clusters that comes up in the personality disorders. So really glad to unpack this with you. But before we kick it off, Shaz, how did you come across Leslie?
Okay, so I've been building my LinkedIn network, and Leslie and I connected a while back on LinkedIn. And as we were going through topics for upcoming shows, I saw that one of her areas of interest was OCD. So sent the invite out, and Leslie came back and said she would love to be a part of the show, and that's how we wound up here.
That is amazing. Thanks, Leslie, for doing that.
Oh, guys, it's my pleasure.
And in terms of social media, is that LinkedIn, are you quite active on it?
No. I wish I could be more active. I wish I had that flair about myself, but maybe in time I'll learn a little bit more and be a little bit more socially active.
Okay, that's cool.
Maybe you guys can teach me.
The reason I asked that is almost everyone, we would be more than happy to do that. But the reason I asked that is almost everyone we ask that question, almost everyone says no. And yet we've connected with so many people, so many amazing people like yourself, on LinkedIn. So obviously it does work in some way or fashion. LinkedIn obviously does an amazing job at reaching, the people, like yourself. So if you want to schedule time, we could do that.
Thank you.
But speaking about OCD, so OCD has so many connotations for me, and I always imagine, okay, I'm not going to show my desk, but always imagine everything pinned straight, like everything in its place. Is that how it is?
No, not at all, actually. So there are a lot of misconceptions around OCD. And that is actually one of the reasons why I was so grateful for this opportunity to chat with you guys. Because we, as a society, have this misconception that OCD is about having a table that's lined up perfectly straight, and we go around and we line up all our paintings, and we often see all these memes on social media. Oh, I've got OCD, da, 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 da. But the truth is, 99% of the time when people are referring to OCD in that fashion, they're actually incorrect. And that OCD has very little to do with perfectionism.
That burst the bubble nicely.
I know, I'm so sorry.
I was like imagining this conversation going like, if you have all of your red hangers in one spot and your blue hangers, then that's probably a good sign of OCD. Okay. So,
no, not even close.
Sorry, I was going to ask, so why is it that we as a society have that conception? I mean, I'm sure I'm not the only one that seems to have that.
No, you're not. I think that Hollywood media, they have played a role in presenting OCD in this fashion. And also I have an Oliver, so if you see a cat wandering around, he's a part of the therapeutic process. Hollywood has presented OCD in that fashion. And I think we make jokes about it, and there is this association with OCD that it's pretty cool to be perfectionistic and to have all your little ducks and hangers in a row. And that's not how it is at all. So I just think it's the transference of incorrect information across society.
Okay, so that's actually really interesting to learn, because like you say, Hollywood and social media have kind of conditioned us to believe that that's what OCD is. It's that everything's got to be neat and perfectly in order, or I've got to check the door 3 times and that kind of thing. So if that's not what OCD is, then what is OCD?
So checking the door 3 times could be OCD. So this is the thing. Obsessive compulsive disorder. We can hear the O, we can hear the C, but there are actually 3 parts of OCD: obsessions, compulsions, and associations. And it's very important for us to understand what associations are, because that is the defining criteria. So all of us actually have some kind of obsession, and we all have some kind of compulsive behavior. So what is an obsession? An obsession is an automatic, involuntary, recurring image, urge, or thought. You know, when you have a song that goes around and around and around and around, you don't have to try and remember that song. It just comes and it kind of harasses you. It almost accosts you, and you're like, don't get that stupid Baby Shark song. Oh my God, when anybody wants to sing, I'm like, don't get it in my head, because I can't get it out. That is an intrusion. You can't get it out and you don't try to get it in. A compulsion is some kind of safety strategy. It can be observable or non-observable. And it's something that the sufferer employs to manage their anxiety or their obsessional distress. But we all have some type of compulsive behavior. For example, when I do lock my door, I will just open the door once and close it just to make sure that I closed it. And also my GHD, I'll go check it once, make sure that I turned it off before I leave my apartment. Those are types of compulsive actions, but those are not compulsions associated with OCD. So this is where the word comes in, association. What makes someone have OCD is the associations that they have because of those intrusions and because of those compulsions. If I had OCD and I had an intrusion, I would have the following association. This is probably going to happen. This intrusion, this thought, this image, it's definitely going to happen. And it's going to make my anxiety go through the roof, and I'm most likely going to lose my mind. And if I don't do something to prevent this, it says something about me as a human being. It says something about me on a moral compass point of view. Whereas if I don't have OCD, and then all of a sudden I'm just walking through the shops and I have the thought, Les, did you turn off your GHD? I would think, yeah, weird thought, of course I did. Someone with OCD would say, oh my gosh, I probably didn't. And the fact that I didn't says to me that I'm completely irresponsible, because now the house is going to burn down and it's all going to be my fault and something bad's going to happen. And so that is the biggest difference.
I love that. And tell me, Leslie, does previous experience kind of play a factor? Because I mean, I love the GHD idea. So if you left the GHD on like 5 times before, maybe in the last week, so when the thought comes up, it's probably going to be, yeah, obviously I did leave it, right?
Yes. So often people with OCD doubt their memory. Whereas as someone who doesn't have OCD, we don't doubt our memory. So the intrusion would be, what happens if you let your GHD on? What happens if your memory is right and you actually didn't remember turning it off? What happens if you think you turned it off, but you didn't? And so those intrusions would constantly place you in a state of doubt to the point of absolute distress.
Okay, that makes sense. And I suppose it's where people become dysfunctional, or they're not like happy with how they are as well, right? I mean, like if you, I mean, like there's a certain level that seems normal. I mean, like if you think, you know, I left the GHD on, I mean, there's a normality around, okay, I need to be worried. But I think where it becomes, like, as you said, like obsessive or over the top, is that how I would explain it as well?
Yes. So it's most certainly a psychiatric disorder, and thus is characterized as interfering with daily functioning and causing significant impairment and distress. And that's what makes it a chronic condition. When people are making when people are making comments about having their table all neatly lined up, we can see that you definitely don't have OCD, because when you were saying that, you were smiling. Anybody with OCD does not smile when they are talking about their compulsions, because they are terribly unhappy. And and feeling quite distraught about their intrusions.
Okay,
So if
that's a good way.
you think you have OCD and you're smiling while you're saying it, you don't have OCD.
Okay, that's a good way to put it.
Yeah.
At least we can look out for that. So if they have that worried look and maybe shifty eyes or something, then you probably have to watch out, because this is probably OCD then.
Well, the unfortunate thing with OCD is that most parents and siblings never ever know that their family member has OCD, because the distress is managed by the individual. It's their responsibility to manage the OCD, so they don't discuss it. And that's why it's so difficult to find warning signs. Unless the individual is opening up, and unless the individual gets stuck in some kind of compulsion loop, you most likely won't even know.
Okay, now you got me really curious, because when when we talk perfection, I always think nail biting, I always think and eating disorders. I don't know, I think it's because of my wife's work, previously, but I just think eating disorders. So how would you spot these perfection, related traits then? What would be things that you would look out for?
Nail biting isn't a perfectionistic trait. Nail biting is there with skin picking and hair pulling, and even pulling on your lips and biting the corner of your mouth, and even picking your skin. As a picker myself, it's the most soothing skill ever. Often when my other kind of OCD related disorders come to see me and they're like, Leslie, I kind of just look at them and say, guys, like, I like picking. So we either just need to get this to a point where it's not dysfunctional, because it's so helpful. It's so soothing. Perfectionism has a different type of soothing technique. It's something that you engage in a conscious way. You activate yourself. It's very directional. You align up everything. Whereas with skin picking or nail biting, you don't even know it and you're biting your nails. Like, one of your friends will tell you, hey, you're biting your nails again. And you'll be like, oh, I didn't even know. So it has more of an automatic process to it.
So just based on that, yes, I'm a picker as well. Especially when my anxiety flares, chew the lips, chew the inside of my mouth, chew my nails, drives my wife absolutely up the wall. But you're right, it is a completely unconscious thing.
Absolutely.
So thinking on that line, would somebody with OCD, although all those thoughts are coming through their mind, well, did I put the GHD off? Oh my God, I didn't put the GHD off. Those are not conscious thoughts. Those are, it's their subconscious almost saying to them that fight or flight aspect. That subconscious is saying, you haven't done this. Oh my God, because you haven't done this, the house is going to burn down. And then that manifests into almost the conscious action of, I've got to leave the store right now to go home and check, did I put the GHD off? Okay.
Exactly. So instead of, I would, when I'm describing it to my clients and their family members, I would say that the part of their brain that I call it the basal ganglion. It's almost like the gatekeeper between the subconscious and the conscious. I would always say to them that their gatekeeper is a bit wonky. He's over enthusiastic and he lets in too many thoughts. And so their wonky BG is what we have as a problem.
That's the first time I've ever heard that term. Is that a psychological one?
No.
I'm kidding.
That's just me shooting from the hip.
Yeah, cool. No, well, as long as your patients identify with it, I mean, that's amazing. But I love that. It also makes it very tangible for me. Like, if it's conscious and if it's like, automatic, or if it's intentional, like, you can kind of see that, but it gives us something tangible that we can kind of watch out for, and say, is this conscious? Like, so things like running, where people say they have to run every single day at like 6 o'clock. And this came up the first time I heard it, with eating disorders as an example. I know we're not talking about eating disorders, but, that seemed to be like a very conscious thing that they had to do, in terms of exercise. Is that something that would be an example?
So that I would say that I can see how there are certain psychiatric disorders that have compulsive type behaviors, where the behavior is recurring. And the individual needs to keep doing the behavior in order for them to feel some kind of relief. But I would say that in OCD, compulsive behavior has a different drive. For OCD, it's about being responsible. Responsibility and morality is a massive underpinning component for the sufferers. They're not checking the GHD because this is a matter of control. It's not about controlling the environment. It's about being responsible in their relationships. And that if they leave the GHD on, they were irresponsible in the relationships that they have and that they value so deeply.
That is amazing. I don't think I've ever heard it said like that. But I can't help but thinking then that was obviously somehow imposed there. I mean, like, how does someone get this overdeveloped sense of responsibility or stuff like that? I mean, like, obviously it had to be something in their upbringing or maybe a traumatic experience. Is that how it normally, or is someone just born with it? Is it a genetic thing? Is it a, nature versus nurture? Yeah.
So we actually don't know what causes OCD, but we do have some clues, and we know that it is definitely hereditary. So if my parent has OCD, I have a 25% likelihood of getting OCD. So this neurobiological disorder has been identified to be associated with 3 regions in the brains that have been particularly hardwired to function in this very OCD way. But there really are also personality traits or components that people with OCD most often have. And one is high levels of perfectionism, and also people who have a very established moral compass. And one of the things that they value is being responsible.
I was going to ask, so how does someone get this high moral compass? Because sometimes I find it lacking, so it's actually a really good trait, that someone does have this. Is there a way to develop this thing?
I have no idea.
Okay.
But I'm sure some of the psychologists would suggest that there is some kind of developmental aspect, has to do with probably parental discipline and child rearing. I mean, that would be a guess, but I have no idea.
Sorry, Leslie. Well, one more thing I just want to ask, responsibility, morality, the whole thing about unfairness, does that come in as well? Because, like the whole, like, me against the world, or, like, I always get treated like this. Does this come up with OCD or no?
So they will have a value system about unfairness, but it won't be a me against the world thing. It will be, this person committed a crime. Like, I'll give you an example. It's so unfair how the individuals in Ukraine are suffering, and I'm over here drinking a cappuccino. That is so unfair. That is an injustice. That is how that value system would play out. Because it's very important for them to be responsible, it would be, this is the way I am, and I need to take responsibility for my condition. So they have a very sensitive internal locus of control.
So just thinking about that locus of control thing. So a person with OCD basically feels that they're responsible for turning off the GHD, to the point where if they don't, they feel that this is going to have negative impacts on everyone around them, because the house burnt down, the family doesn't have anywhere to live, and it's now all their fault because they didn't turn off the GHD, as opposed to me, who would forget to turn off the GHD and go, okay, well, oops, my bad. And remember, next time before I leave the house, just double check the GHD. It's that intense feeling of, if I don't do this, something bad's going to happen to the people that I love or am responsible for, and it will be my fault.
Yes. So they overestimate their responsibility in maintaining the well-being of those that they love and those that they have in their circle of trust.
So that would then explain almost that obsessive compulsion to check that the door's locked, every door and every window in the house is locked at night. It's not about, is the door locked? It's, if I didn't lock the door and a burglar gets in, it's my fault because I didn't go and check that all the doors were locked, and that all the windows were closed.
Yes, so I share responsibility with the burglar. So in with that type of OCD, I call it like shared harm. It would be, if I could have done something to prevent it and I didn't, I am responsible.
Okay. That is like really, so you said with that type of OCD. So does that mean there are different types of OCD?
Yes, exactly.
What would the different types of OCD be?
So literature has presented subtypes of OCD by almost like categorizing the different intrusions and then the different compulsions. But I find that too confusing. So what I do in my practice is that I divide OCD based on the different types of intrusions that they get. And intrusions vary. So we get intrusions of violence where we are afraid that we have the propensity to probably cause harm to someone we love in a violent way. So that's what we would call violent harm OCD. We then get religious OCD, where we are getting blasphemous thoughts. And that can often like shift over to scrupulosity OCD, where we become quite pedantic about doing the right thing and not transgressing. And the compulsion would be confessing and checking that you haven't sinned. Making a mistake, losing something, contamination, sexual intrusions, where you are afraid that you may have the urge or the capacity to cause harm to another human or even a child. Those pedophilic intrusions are so distressing that they are crippling. So, I mean, there's like so many lists. We do have some symmetry. We have relationship OCD. We even have existential OCD, where we become preoccupied about doubts around meaning and purpose and death. And we have doubts about being awake or real, and we wonder if we're in a dream state. I mean, these are the OCD intrusions that we don't really hear about ever, but people suffer with them daily.
You're right. I mean, I don't think I've heard of it like that. I mean, we just blanketed it. I mean, again, I gave the hanger story. I always thought it was like that. But, you know, the more I hear you speak, the more I feel sad, because, I mean, these people, I mean, like, they really struggling and suffering through this stuff. And I can kind of see that, you know, I can kind of see, you know, I think the one that really brings it to, you know, like, brings it to ground for me is that the burglar one, because I don't think it's normal to think like that. But, you know, like when you're thinking, actually, it's my fault that the burglars are here, or I helped them in some way. I mean, that must be quite difficult, you know, as a, you know, for a person actually to go through. So
it's debilitating. It's debilitating. So in literature, we would call that checking OCD. But the intrusion is a harmful thought that something bad is going to happen to the people that I love. And if I don't check this, I share responsibility. That thought, I mean, those thoughts can start as young as 15, some even 12, depending on the severity of the condition. And then they go around checking all the windows and making sure that they did it right, and having these magical numbers and making sure that, okay, I did the right thing. Okay, everything's going to be okay. My family's going to be okay. I'm going to be okay.
Yeah, I mean, that's amazing. And I can't help, and I think, you know, we asked the question, but I do want to ask again. I mean, so what causes it? I mean, you know, and I think you answered it, but maybe just one more time. And I'll just, before you do, I mean, I'll just tell you, like with me, you know, growing up, I mean, you know, my dad left quite early on. And so I always had this responsibility that we had to, you know, to take care of the family, you know. And it's almost like when you speak to people later on in life, so we've got 2 kids now, and obviously they don't have any of that drama. So like, and whenever we speak to people, you know, they always say, actually, that's how it's supposed to be, you know, carefree, you know, they always forget things, all of those things. Whereas like, you know, in our family, it's like, if you didn't do that, exactly what you just said now, you know, it's almost like you're letting people down. You almost like have this overdeveloped, you know, sense of responsibility. And I think, you know, so I can't help but think, you know, like there's always something that causes it, you know, like this, like in my case, it's probably, well, not that you said I don't have OCD, so I'm going to hold you to that. But, you know, in my case, it's not, it's hasn't really affected, like from that perspective, but definitely it gives me a different lens on the world, that I find our kids don't have. And so, coming back to the question, like, so is there something that causes it? I mean, traumatic life experience.
Yes. So, like I was saying earlier on, we actually don't know what causes OCD, but we definitely have some clues, and we know that it's a genetic condition. We know that it's neurobiological, and certain parts of the brain have been hardwired to cause OCD. We also know that there are psychological factors like perfectionism and this responsibility and the values and morality. But another value system that is a common trait in people with OCD is that they value their family and their close relatives more than anything else. It is their currency. Connection is everything for them. It's more than money, it's more than fame, it's more than success. So that is something also to remember. And then you are right, there's most certainly are environmental factors that contribute to the cause. Trauma can absolutely be an issue, but we would still need that genetic factor, kind of like the diathesis stress model. We can have a trigger in the environment, but there needs to be this genetic vulnerability. And then there are pathogens. If you get scarlet fever or some kind of strep throat when you were younger, and that condition, that pathogen goes into your head, you can get something called PANDAS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder. And PANDAS is an autoimmune condition that causes OCD in the children. And then you actually have to manage it like an autoimmune. And head trauma can cause OCD. I know I've seen clients who have epilepsy, and depending on where the seizure activity is happening in the brain, especially if it's near this nucleus accumbens, or the parts of the brain that are responsible for the OCD type thinking and behaving, that seizure activity can cause OCD looking behavior. So that's also a thing to consider.
Okay, that's amazing. I actually learned a new term as well, panda. Well, except for the animal, in computer science, there's a term for pandas, in deep learning. But yeah, I didn't know it's also in the psychological realm, which is amazing.
Yeah.
And is there a certain, and again, maybe we're repeating this, but like with schizophrenia, it has to present by a certain time, or else, probably you're not going to be schizophrenic. With OCD, is there a certain time frame like that in terms of how young it can start? I mean, would you see like a 2-year-old with OCD, or does it come up at a certain time, like teenagers, with eating disorders? It seems to be the general trend. That's when it starts.
So, if we have to deal with the South African population, we have 60 million people in our country. According to the stats, 2% of our country has OCD and OCD-related disorders. So that's 1.2, 1.5 million. It's a lot. And they're at the stats, according to the stats, OCD starts before the age of 10, and this is most common in boys. With girls, OCD is starting to show itself more in adolescence, but most people have OCD by the age of 23 to 25. However, what I've seen in my practice is that when I sit with my nunus, and those are my clients, they all have little nicknames. When I sit with my nunus and I ask them, when was the first time you started having these thoughts? A very common thought is, I don't know if I'm awake or asleep. They remember having that thought when they were little. And I'll say to them, do you remember being so afraid that mom and dad would die? They'd be like, yes, I remember having that thought. So we can see that already then their basal ganglion was allowing these very scary thoughts to come through. And they just carried on plodding around because the other parts of their brain that is responsible for OCD hadn't fully developed yet. So we see these early signs, but only in retrospect. Because when they're that age, they don't know they're abnormal. They were like, Les, I thought everybody had those thoughts. And I'm like, no, my nene pants, I never had those thoughts. And they're like, what? What do you mean you never had those thoughts? I was like, no, did not have them. And then they kind of start to see, oh, so I should not be having this. And I'm like, no.
That's amazing, eh? Communication.
Yeah.
I had this friend, and he couldn't see for a long time, but he didn't realize he couldn't see. And eventually he went and got glasses, and he was like, wow, you actually can see the leaves on the tree. And, but You just thought that was normal. I mean, I thought that was the
Yeah,
most amazing thing ever. But exactly what you just said now, I mean, that is incredible. But it just shows you, I mean, each one of us, I mean, this is the thing that fascinates me. We all have our little worlds, and this is like everything for us. But, we almost never, like, think sometimes to ask the other person, like, are you seeing the same thing? And it's actually fascinating,
it
even how
is
you
fact.
said that. I mean, I love that in terms of, like how they see it.
Yeah, what's a very tragic situation is that the younger the OCD starts, obviously, the more severe the prognosis is. One of my clients, she has severe OCD, and her little boy, he's young, below the age of 5, and he started having intrusions already. So it is a very, very debilitating condition, and we can see that this little Nunu is already taking strain.
That's just so sad to hear, because at the age of 4, it's already starting to take an effect, and obviously, as he gets older, without treatment, this is going to get a lot more intrusive for him. So,
Yeah.
just on that subject, I mean, how do you help or treat somebody with OCD to almost start managing those intrusions? Is there a way to manage them? Do you help them with coping mechanisms? I mean, otherwise, we'd have 1.5 million people all living in their bedrooms, terrified to go anywhere.
So I think that there are 2 golden standards for the treatment when it comes to OCD. And the first one is medication, pharmacology, and then the second one is exposure and response or ritual prevention therapy, which is a subtype of CBT. I would say that depending on the severity, both are always the right way to start, because OCD, like we were saying, is neurobiological. It hasn't been caused by some kind of parenting subtype or any kind of destructive relationship in the household. You were born this way. And if it is that young, then I think seeking the help of a psychiatrist who has special training in OCD is probably the right way to go, because the medication has a profound impact on influencing how frequent you get these intrusions and how graphic they are. So if you're having 20 intrusions an hour, some medication can reduce that to 2 or 3. That is life-changing.
That is amazing. And I'm glad you mentioned, the medication. I didn't think of like medication. I can kind of think now maybe, like anxiety and stuff like that, that obviously works. I love the exposure idea and the CBT stuff that you mentioned. And the question, I mean, she has mentioned a really cool question, around the treatment. Is the prognosis good? I mean, from what you see in your practice?
Yes, the prognosis is good. In my short career of treating with OCD, I've only seen one type of refractory or treatment-resistant OCD that didn't work to all the types of therapies, including the most aggressive, like the deep brain stimulation. And that is just probably a case that will break my heart for the rest of my life. Yeah.
Sure. Yeah. I think it's the perks of the job, it seems, eh? Sometimes you just can't help everyone. I think maybe that's the lesson learned.
But fortunately, everybody else has improved.
Yeah,
and we can so we can celebrate for them.
100%. Yeah. And I was just going to say, it's amazing. It's because of amazing people like yourself. I mean, like, I think overall it's better. I can't help but thinking about that 2% idea, or that stat, and wonder how they got that. Because I never came across any consent, survey or some stuff like that. So it's interesting, how statisticians, come up with these numbers. But it's interesting for me, seeing that. In terms of your, you mentioned psychiatrists now, but do you find that you work in a multidisciplinary team, even if that's virtual? Do you find like, this type of condition, OCD, is concentrated around certain practitioners that work with patients? So psychiatrists definitely. I'm presuming, maybe a GP at some point probably picked it up, and then obviously yourself, as a psychologist. Do you find any other types of practitioners?
So depending on the clients, so it also depends on what kind of comorbid conditions that we have. If we have an epilepsy, if we have a PCOS, that would then extend our MDT. But ultimately, it comes down to a psychiatrist who's trained in treating OCD and a psychologist who is skilled in ERP. And then that power couple, we would then extend depending on the comorbidities. We would bring in a gynae, we would bring in an endocrinologist, we would bring in a rheumatologist if they're autoimmune conditions. If we decide to do some kind of deep brain stimulation, you would bring in a neurosurgeon. So it really does present on the case. Depend on the case.
So it can actually be quite a large multidisciplinary team depending on the severity of the case and obviously what comorbidities the person themselves has. Okay, that's really interesting. But you mentioned EMR. What is that?
ERP.
ERP, sorry. Yeah.
No. So ERP is the second part of the golden standards for treating OCD. It's a branch of CBT, but it's more the behavioral part. It's a behavioral therapy that works with the intrusions and desensitizes them to the OCD sufferer, and it ends up resulting that they cause a significantly less distress. What is a defining criteria of OCD is that the sufferers have both the intrusion and the logic, and the logic that their thought is so irrational. And so that awareness is, in my opinion, and I actually share this opinion with Professor Christine Lochner, one of the reasons why OCD is such a debilitating condition. If I was manic and I thought that I was able to heal the world, I would be loving life right now. I would be high on my euphoria and loving these grandiose thoughts about myself. But with an OCD sufferer, they don't ever experience that. They're very aware of their irrationality, and that is often what drives them to that point of significant distress. So they will hear what happens if you actually do have the capacity to hurt that child. And then they'll go, but I don't, I know myself. That's why am I having this thought? But what if you actually do have an urge? I know this isn't me, and so this internal dialogue. So it's what happens with ERP is that voice, that rational voice, after a sufficient amount of exposures, becomes a lot louder, and the intrusions become a lot softer. So then they'll say to me after an exposure, no, Les, no, I'd never do that. No, never. Because they finally can grab or hold on to the logic, whereas before they couldn't.
Yeah, again, going back to that word sad, and it must be like very, I don't know, I'm thinking involved, but not involved, frustrating or time consuming, stuff like that. It must be, it must take a lot of energy, let's just say it like that, within, to have that conflict all the time. And
Yes.
I'm just wondering, like, because you have to do life, like you have to go to work and stuff like that. How do you find, like, with your patients, how do they present then at work? And do they, can they keep on like stable jobs, or does it become quite a problem?
I think what you have suggested now is so accurate. They live two lives. They live the OCD life, and then they live a life like you and me. So where they don't have intrusions and compulsions, they don't know what to do with their time. Like your friend was saying, for the first time, he can actually see, and he's like, wow, I didn't know how blind I was. My newness will say to me, Les, I didn't even know my brother had green eyes, because I was so caught up in my internal world, I was never fully present. So they live two lives. Depending on the severity of the intrusions and the compulsions, it can get to the point where their life gets just about the OCD, and they get caught up in OCD loops that can last 25 minutes, an intrusion, up to, you can get caught into a compulsive loop that can last up to 28 hours.
Wow. Sure. That must be quite mind-numbing, eh? In terms of 28 hours.
Soul destroying. It's
Yeah.
soul destroying.
Yeah. Well, that's a better term, actually. Um, and in terms of substance abuse, I mean, we had someone on recently and she just launched a book, and she talks about being an alcoholic, so substance abuse. But do you find OCD, or is that completely, based on the moral compass, they're probably not going to go down that route?
So because of their intrusions, so OCD will go after your intrusions will always go after the things that you value. So I have no attachment to polony. So if I had OCD, I'm not going to have intrusions about polony. I'm going to have intrusions about everything I love, like my people and my animals and my work and so forth. So when you're having intrusions about the things that you love, you're afraid of losing the things that you love. And so let me just try to think how to explain this. So it would be, okay, let me actually just add a point, because this is something I wanted to say. One of the reasons why a psychopath could never have OCD is because if he had to have an intrusion about having the urge to assault a child, it wouldn't cause him distress because his value system is corrupted. Whereas someone who has OCD, that thought is so terrifying that it actually interferes with everything, with their lives and so forth. And so depending on the type of thoughts and how frequent the thoughts are, their world can become smaller and smaller and smaller and smaller and smaller until eventually it's just OCD.
Right. So just following on the train of thought, though, we know that human nature is, in some ways, we do try and self-medicate. Would somebody with these intrusive OCD, these intrusions coming all the time, would somebody like that be likely to turn to self-medication through various different, to try and get rid of those intrusions?
Thank you for asking that, because I was thinking now and I had my own intrusions and then I forgot what the question was. So thank you for throwing me a lifeboat. Okay, so my value system is intact. I don't want to hurt anyone. If my drinking would cause anyone harm, I am causing my greatest fear to come to life. So out of my clients, when they do try substances, their OCD will go, but what happens if you get cancer? It's going to be your fault, and you're going to be the reason why your family suffer. So then that one joint or that one something that they tried was so debilitating that it was actually not even a nice experience. And then they're just like, no, Leslie, I can't. And also some of the substances, like for example, cannabis particularly, and certain alcohol actually, like my clients, especially my adolescents who are experimenting and being like typical adolescents, there's certain alcohol that actually exacerbates their intrusions and their compulsions. Vodka, I don't know why, it does that to them. So a lot of them stick to whiskey and gin. It's the strangest thing, and it's what they all say, and I can't find literature on how vodka exacerbates OCD. So it's just something I'm seeing in the practice. I tell them the definition. I tell them not to touch vodka and cannabis. I don't know why, and I'm sorry for the vodka producers out there. But that's just what I've seen. So I haven't encountered anybody with OCD and an addiction. But never say never, I guess, because you never know what could happen.
Any correlation with potatoes and OCD?
I have no idea.
that would tie up the podcast.
Hilarious. If there was some kind of gastric something connection.
It's funny.
That is funny.
Tell me, if we want to learn more about OCD, not that we're going to be doing too much of reading, but just say as a parent and they kind of looking at their child and say there's something not quite right, where would you point them to? Are there specific resources, books, or anything like that you came across that's pretty amazing?
So South Africa is pretty amazing. We have an amazing OCD expert. She is a psychologist. She is from Stellenbosch and UCT. Her name is Professor Christine Lochner, and she is running one of the world's largest OCD trials. And she heads up the Mental Health Information Center. So they have a website and they give wonderful definitions about what OCD is. And they also have a directory of psychologists that work with OCD, because it really is a specialist field in itself.
Yeah, that is amazing. I mean, most of the time I don't look at, who the guests are coming up. But so when we had Charles on speaking about personality disorders, and he mentions OCD specifically in one of the clusters, and I thought that was amazing. And then when I was looking, last week, I'm looking at this week's agenda, and I see OCD. That's amazing. I mean, it's funny how Shaz picks this up and runs with the schedule, but it's incredible. And what you just said now is incredible, because, and we'll have a link to that. I think if you just provide that to you, we'll put it in the show notes. But what you said is amazing, is because there's people that specialize in this, and I think that's the amazing thing of the world, in terms of the world that we live in. If you are struggling, there are people like yourself and that directory that you mentioned of people that can probably help you.
Yes.
I think you're almost like, when you were with our kids, there's always these stories about like potty training, and, they always like dumb it down a bit, right? But you almost like need this from a psychological aspect, if your child is doing this, but, in a story format, that would be amazing.
So what are you saying? We kind of need like potty training, but for like psychological first aid.
Yeah, exactly.
I think that's genius. That's a genius idea.
Yeah, I'm sure, because you watch some of these cartoons. I mean, I know you mentioned the one, I can't remember the song you couldn't get out of your head. But
no, don't go there. Don't go there.
Let's not go there. But like Peppa Pig. I mean, like with our kids, sure, we watched lots of Peppa Pig. Fortunately, our adult, our older one, she was into Barney, but our younger one, he didn't want anything to do with Barney. So we got that one out of the system. But yeah, stuff like that. They bring up these things, but we started the discussion by talking about all of these stereotypes and misconceptions we have in our head, even as we started this conversation, which is going on for an hour now. But even as we had this conversation, my misconception was clearly evident. But I think what you just did, in less than an hour, was dispelled all of that and taught us pretty much how difficult this condition is, and what we probably need to look out for. And I think I'm probably not the only one that says this, but we definitely need that level of instruction or resources.
Yes.
Because I think therapists like yourself are amazing, but you have all of these resources, and I think that's the reason why we're doing the Moulding Health show as well. You have this, but it's like within the community, but you don't need to help those people. You need to help everyone else. Like, how do you make that accessible? And so it'll be interesting to see how that space evolves. But as you said, the professor, people like yourself, everyone on that directory, I mean, I think you guys are doing an amazing job by just pushing it forward and also specializing.
Yes,
so that yeah.
I think that with your previous guest, I even think there is this misconceptions amongst the professionals. They even think OCD is about symmetry. And yes, there is a symmetry and alignment. That would be the compulsion, but the truth is, what is the intrusion? And then what are the associations? And OCPD, Obsessive Compulsive Personality Disorder, is very different to OCD. OCPD has more of a perfectionistic underpinning to it, and OCD has this relationship and then this responsibility and this relationship association. So they are very, very different, and treating them is quite different as well.
Okay. I think we're coming to the end of the show, and we obviously learned something almost like fundamental, with that as well. I didn't know that, and that's maybe what he was referring to as well. I thought what he did say, and I would love to get your opinion on this. He said, we almost, when we go for a flu, like let's just say we had COVID even, and you go and COVID is over, but you don't have COVID for the rest of your life. You just have it for that time. And I think you almost like get caught up in this diagnosis thing for people. Like you have OCD, but you have it for the rest of your life. But that's actually not true, probably, because as you said, the prognosis could be good. Do you find that OCD, I mean, is it that once you got the diagnosis that it's for the rest of your life?
Yes.
Okay.
It's a chronic condition.
Okay.
And I think that the diagnosis is particularly important for sufferers of OCD because for so long that they thought that they were evil or corrupt. And to find out that this is a condition and that they have this wonky basal ganglion is life-affirming.
Just going on what you're saying there, Leslie, is I definitely agree that getting a diagnosis immediately helps a person because they now have an understanding that, okay, this isn't just there is actually something that is there. And from there can actually start looking at, okay, how do I treat or manage this? Much in the same way somebody that maybe gets diagnosed with diabetes. It's chronic, it's going to be there for the rest of your life, but you can manage it. And in order to manage it, obviously, there is the pharmaceutical route, but you can't just use the pharmaceuticals. There is also the therapeutic route that has to come with it in order to manage the condition, because if you don't, it's going to revert back to that horrible, nasty state you were in before the diagnosis because it's not being managed.
Yes, and I think that when OCD is just managed with ERP, so without the pharmaceutical aspect, it's the severity of the OCD it's mild. It's more mild.
That is really amazing. So we're going to close up now. It's amazing talking about this, and it's funny how fast time flies by. But thanks, Leslie, for everything that you do. I'm going to ask Chaz, anything that we missed on that we should have asked Leslie, and then we'll ask Leslie for her closing thoughts as well.
I don't think there's anything that we missed. I think obviously going in, we did have a couple of preconceptions about what OCD is and just had the tables turned completely on that, which is a really good thing. And that's what I'm really hoping people who listen to this will get out of it, is that this isn't just, I've got to have all the red hangers in the same place. So yeah, I think we've covered the subject really nicely. I think there's obviously a lot more we could talk about, but that would have to be in another show. No. So thank you very much for everything, Leslie.
It's my pleasure. Thank you.
And Leslie, on your side, we try our best in layman's terms to come up with the best brief. I thought Shaz was being very brave by asking what gender would you answer that question? Which gender does it present with more? But I think you answered that question in your, when you were answering one of the other questions. But is there anything around this topic of OCD? I love what you said about OCD and OCPD. I thought that was amazing. But anything else like that you thought we should have asked you, but we didn't?
So I think just to elaborate on the associations that people with OCD have, those being that I'm going to lose my mind and that I'm a morally corrupt and evil person. Those associations are just quite debilitating and they feel completely alone, and there's a lot of shame with that. And if there was anything I had to add, I would just say that there really is help for sufferers of OCD, and that this condition is not their fault, and that their suffering their suffering can end, and they can get treatment, and they can get their lives back, and they don't have to feel like they're entrapped or held prisoner by their own minds. There is help.
Yeah, and that's the reason. I mean, I think I've said it already, with the show, but having amazing people like yourself that work with your nunus and help us understand that a lot better. But that's incredible. I think we live in a world where you just have to reach out, and COVID for me, we've been preaching about this for a long time, the whole online space, with our clients. But what it's opened up for us is access to people like yourself, healthcare practitioners that are open to having online sessions, or online mediums. And that's incredible. So thanks very much for what you're doing. Thanks for agreeing to do the show. And thanks very much for bursting all of our bubbles around OCD.
Of course, it was my pleasure.
Hey, everyone. Thanks for listening. As always, stay tuned and we'll speak to you in the next episode.